Hello, and welcome to the RSNA Radiographics Podcast. I'm Maya Patel, a fourth-year radiology resident at Jefferson Einstein Hospital, Philadelphia.
And I'm Tetyana Gorbachova, clinical professor of radiology and section chief of musculoskeletal imaging at Jefferson Einstein Hospital, Philadelphia.
Today, we are excited to talk about our radiographics article titled Charting Variant Vascular Pathways in Musculoskeletal Imaging, Clinical and Surgical Implications. Thank you for joining us as we discuss variant anatomy in the upper and lower extremity.
Variant vascular anatomy is not just for interventional radiologists. We musculoskeletal radiologists encounter these variants during routine examinations, but we're looking at the vessels through a small window. The field of view of typical musculoskeletal imaging exam is tailored to evaluation of the joints and gives only a limited coverage of the vessels. Plus, let's face it, we may be less familiar with these vascular variants and their significance. With these limitations, we'll still have full responsibility to recognize the aberrant vasculature, to assess its clinical significance as the source of patients' current symptoms, and have the knowledge of associated risk of surgical complications. While often an incidental finding regarding the clinical indication for the imaging study, vascular variant anatomy may carry a risk of iatrogenic injury during surgical procedures that may be contemplated to treat current problems or future surgeries for other conditions. So we thought that a focused review of prevalence and anatomy as well as clinical significance would be beneficial to our colleagues in diagnostic radiology as well as interventional radiology and orthopedists, as they are commonly the ones assessing patients for surgical treatment where variant anatomy may be relevant.
For this reason, we definitely needed all hands on deck and assembled a multidisciplinary crew with co-authors from interventional radiology and orthopedic surgery. In the article, we focus on several variants that can be encountered on routine musculoskeletal imaging studies. For each variant, we report prevalence, highlight anatomic landmarks that allow identification of both normal and variant anatomy, review clinical significance of the aberrant vasculature, and discuss potential risk of surgical complications. In this podcast, we will give some of the highlights that we definitely don't want to be missed.
So let's get started in the upper extremity. I know you have your favorite variant there, Maya, right?
Yes, persistent median artery is a vessel in the volar forearm originating near the antecubital fossa from either the ulnar artery, common interosseous artery, or anterior interosseous artery, and may exist as the antebrachial or palmar pattern. The antebrachial pattern, which is the more common of the two, terminates proximal to the wrist, while the palmar pattern extends distally to the transverse carpal ligament and contributes to the arterial supply of the hand. Persistent median artery is notably associated with another anatomic variant, the bifid median nerve, which is the division of the median nerve before the distal radial ulnar joint and either proximal to or within the carpal tunnel. On imaging, persistent median artery is best identified in short-axis ultrasound or axial CT and MRI images as a vessel accompanying the median nerve. In the palmar pattern, it has a superficial course within the carpal tunnel immediately beneath the transverse carpal ligament. So look for a small arterial vessel deep to the transverse carpal ligament, often located between two trunks of the bifid median nerve. For me, this might be my favorite variant because it can have variable and unique clinical presentations, including median neuropathy or digital ischemia. Specifically, carpal tunnel syndrome related to the persistent median artery can have two distinct clinical presentations. The first, with thrombosis of the vessel, presents with acute, often severe, onset of pain and paresthesia. Our orthopedic surgeons like to describe it as patient is having a colic in their wrist. The second is associated with a patent artery, where a more insidious range of symptoms predominate during work. It is amazing how one variant can cause such distinct, extremely different clinical scenarios. But we have a couple more to discuss, so let's let our listeners decide their favorite.
So on to our next variant, for which we'll stay in the upper extremity, but now at the elbow, we have the brachioradial artery. Our interventional radiology colleague actually educated us on this one. This variant refers to a high division of the radial artery above the antecubital fossa from either the axillary or brachial artery before following its conventional course along the radial aspect of the anterior compartment of the forearm. On imaging, brachioradial artery can be identified on axial CT and MR images of the elbow when instead of a single arterial vessel in the antecubital fossa, the brachial artery, you see two adjacent arterial vessels above or at the level of the joint, with the radial artery, now named brachial radial artery, having proximal origin from the brachial artery or from the axillary artery. While there are no proven clinical associations with the brachial radial artery, the surgical implications are more defined and pertinent in reconstruction surgeries and vascular cannulation. Given the use of radial artery in CABG and flap reconstruction cases, knowledge of the deviant course can be valuable in preoperative planning. Additionally, increased tortuosity of the vessel leads to greater risk of transradial catheterization failure. That wraps our discussion on the upper extremity. Now we can move down and start in the lower extremity.
At the pelvis, there is corona mortis, a venous or arterial anastomosis between the obturator system and either the external iliac or inferior epigastric system.
Corona mortis, that is a fun and scary name.
Yes, this vessel is aptly named with the Latin translation meaning crown of death. The vessel originates from the external iliac artery or inferior epigastric artery, drapes around the superior pubic ramus like a crown, and continues on its way to the obturator canal. Laceration of corona mortis may accompany pelvic fractures and lead to life-threatening hemorrhage, as the name aptly applies. The name of crown of death serves as an ominous reminder in all pelvic trauma cases, where large pelvic hematomas may be a result of an injured corona mortis. For our next variant, we'll stay in the pelvis and highlight the persistent sciatic artery. Persistent sciatic artery is a vessel that continues directly from the internal iliac artery to the posterior thigh and may continue as the popliteal artery. On imaging, persistent sciatic artery notably accompanies the sciatic nerve through the infrapiriformis compartment of the greater sciatic foramen. So look for an arterial vessel traveling with the sciatic nerve. Given this proximity, persistent sciatic artery can present with symptoms of sciatica if the artery thromboses or enlarges, causing compression on the adjacent nerve, while a milder presentation is a sensation of fullness in the inferior gluteal region or a pulsatile gluteal mass. One of the most common and most severe clinical presentations is arterial insufficiency, which may range from claudication to severe limb ischemia, with some cases even necessitating amputation.
Next, let's follow the vascular anatomy down the thigh to the remainder of the lower extremity and discuss the knee and the ankle. Aberrant anterior tibial artery, probably my personal favorite, is the high division of popliteal artery when the anterior tibial artery originates above the joint line and above the superior margin of the popliteus muscle and courses between the popliteus muscle and the tibia. On cross-sectional imaging, aberrant anterior tibial artery is best seen on axial and sagittal images as the vessel branching from the popliteal artery above the popliteus muscle, coursing in close proximity to the posterior knee capsule and passing between the popliteus muscle and the posterior tibial cortex. So find the popliteus muscle and look for the artery anterior to it. Now, this is the vessel that initially sparked our discussion and this whole project, given the numerous conversations with our orthopedic colleagues regarding the risk of iatrogenic injury in several procedures. Risk of injury presumably stems from the relatively fixed course of this vessel, close to the posterior knee capsule and posterior cortex of the tibia, all while being supposedly held in place by the overlying popliteus muscle. So total knee arthroplasty, high tibial osteotomy, tibial plateau fixation, PCL reconstruction, arthroscopic repair of the lateral meniscus, and even some techniques for posterior lateral corner reconstruction are all procedures that involve anterior to posterior instrumentation of the tibial cortex, where an extension of the saw, a screw, or drill beyond the posterior tibia may injure the vessel. Iatrogenic injury can have severe clinical repercussions, with reports of compartment syndrome, serious hemorrhage, and limb ischemia necessitating amputation in some cases. So, preoperative knowledge of variant anatomy allows surgeons to take proactive steps and operate with a heightened sense of awareness of this variant.
Preoperative awareness has been an important theme throughout, and our final variant is no exception. Perineal arteria magna refers to a congenital dominance of the perineal artery as the sole vascular supply to the foot that branches into the posterior tibial and perineal arteries and continues as the dorsalis pedis artery. This same morphology of continuation of the perineal artery as dorsalis pedis may also be acquired secondary to trauma or peripheral arterial disease of the anterior tibial artery. Additionally, lateral course of the dorsalis pedis can be seen with conventional anatomy when it originates from the anterior tibial artery or variant anatomy with dorsalis pedis artery supplied by the perineal artery. On imaging, dorsalis pedis artery can be followed proximally on axial images of the ankle to determine its origin and course. In the lateral course, the vessel runs anterior to the tibiofibular syndesmotic ligaments in contradistinction to its conventional path midway between the lateral and medial malleoli. In these cases where the perineal artery is the dominant arterial supply to the entire foot, it's no surprise that iatrogenic injury can cause foot ischemia with severe outcomes even leading to amputation. Injury may occur from anterolateral portal placement during ankle arthroscopy or laterally directed instrumentation during lateral approach total ankle arthroplasty, syndesmotic screw fixation, or posterolateral tibial fixation for trimalleolar or pilon fractures. Additionally, perineal arteria magna should be identified prior to fibular flap procurement in reconstructive surgeries for electrical burns, ulcers, and oral cancers, as resection of the artery with the fibular flap would also jeopardize the sole pedal artery supply.
With that, I think we have successfully completed our voyage. So, compartment syndrome, neuropathy, limb ischemia, these are all serious clinical scenarios that can result from these vascular variants. Now that we know what to look for, we can take care to note their presence for potential immediate or remote surgical intervention. In our practice, we emphasize the presence of vascular variants by documenting them in the impression section of the report.
We hope you enjoyed our outline of vascular variants that may be encountered on musculoskeletal imaging, with highlights of the clinical and surgical considerations. I'd like to thank our co-authors, Dr. Sarah Silberstein, Michael Farah, Sharif Said, Andre Taluka, Jean Schaefer, Garrett Kavanaugh, and James Raphael for contributing to this article. Additionally, thank you to the listeners, and please remember to rate, review, and subscribe to the podcast. Interacting with the podcast helps others find the show and expands the audience. If you enjoyed our summary and would like to read more and learn about our accompanying imaging cases and anatomic figures, please check out the journal website to read the full article and check out other great published works. Thank you again.
Thank you and bon voyage!